Welcome to the webinar Implications of Section 1557 of the Affordable Care Act for Language Access and Provision of Language Assistance to Limited English Proficient patients. I am extremely honored and excited today to introduce to you our presenter, Mara Youdelman. She is my fellow co-founder of CCHI, Certification Commission for Healthcare Interpreter, and she was the first chair of CCHI. Mara is the managing attorney at National Health Law Program in Washington, D.C. office. She leads and helps work on eligibility and enrollment issues, as well as language access and health disparities. She also helps coordinate and helps regulatory and administrative work, including authoring and editing many of comments on proposed regulations. She's a recognized national expert on language access and healthcare settings. She has written a number of reports and participated on expert advisory panels on this subject. She served as an editor and co-author of the NHealth analysis of the Affordable Care Act. She directed the National Language Access Advocacy Project, which was funded by the California Endowment to increase awareness of language access issues at the federal level. She also served, as I already mentioned, as a founding commissioner of the Certification Commission for Healthcare Interpreters. She was named a 2011 Language Access Champion by the National Council on Interpreting in Healthcare, NCIHC, and a 2010 Health Reform Champion by the Summit Health Institute for Research and Education. She also founded AWARE, actively working for acquaintance rape education, an interactive educational program on acquaintance rape. Prior to joining National Health Law Program, she completed a teaching fellowship at Georgetown University's Law Center Federal Legislation Clinic and spent 2 years litigating for the Administration for Children's Services in New York City. She earned her degrees in advocacy from Georgetown University Law Center and her JD from Boston University School of Law in 1996 and her BA from Tufts University in 1991. Mara, welcome.
Thank you so much. I'm really happy to be with all of you today, and I'm glad that you could join us. I'm going to be talking about Section 1557 of the Affordable Care Act, also known as Obamacare, which is the non-discrimination provision. We're going to start with some general background just to make sure everyone is up to speed and we're on the same page here. First, if you're not familiar with the National Health Law Program, or NHealth, we are a national nonprofit public interest organization. I'm in our DC office, although we also have offices in Los Angeles and North Carolina. And we litigate, advocate, and educate to improve healthcare access and quality for low-income and underserved populations. And I've been working at NHealth for over 16 years and doing language access work since about my second week at NHealth, which is right when President Clinton actually signed Executive Order 13166, and then HHS put out its very first LEP, or Limited English Proficiency Guidance. So I've been doing this for a while, and I'm really excited to be able to talk to you about some of the more recent developments and where we'll be going in the coming years. So in terms of demographics of the United States, many of you have probably seen this or similar statistics before. I have to apologize, I'm getting over a cold and a cough, so I might cough a bit during the presentation. But about 20% of the population speak a language other than English at home, and about 9% of the population would be what we called LEP, or Limited English Proficient. And by that, we look at a question that's asked by the U.S. Census Bureau when they administer the census and the American Community Survey. And they ask respondents, how well do you speak English? Do you speak English? And there's 4 answers. Very well, not at all. For the purposes of healthcare, when we're really talking about a high level of technical terminology, we all know it's sometimes hard for English speakers to understand the terminology when they go to the doctor, but anyone who speaks English less than very well is likely considered limited English proficient and is going to need assistance in overcoming language barriers in a healthcare encounter. It's also important to note that over 8.5 million children live in a household with at least one LEP parent. And while those children might be English proficient, it's just as important to make sure that the parents or their guardians are able to get language assistance when they're bringing their children for medical or health care visits, in large part because many of those visits might require getting consent from the parent, even for something as simple as giving a flu shot, or certainly a more complex medical procedure or surgery. And if the parents aren't provided with language services, then they're not going to be able to provide the necessary consent. In terms of treating LEP patients, these data points come from surveys that NHELP did a number of years ago, so it's likely the numbers actually may have increased. We first did a survey with the research arm of the American Hospital Association and found that 80% of hospitals are encountering LEP patients at least daily, weekly, or monthly. And that's pretty significant, and that is across the entire country. It's not what we often think of the myth of where immigrants are or where LEP individuals are being in the big states like California and Texas and Illinois. This data point actually is every single hospital across the entire U.S. are seeing LEP patients generally at least daily and weekly and then monthly. We then did a similar study with the American College of Physicians, which is an organization representing general internal medicine physicians, and found a very similar statistic. And then even higher percentage of FQHCs, or federally qualified health centers. These are like your community health centers, whereas most of the FQHCs are actually seeing LEP patients daily. So this is an issue that comes into play across the entire United States, whether you live in a big city, a suburban area, a rural area, whether we're talking about hospitals, clinics, or small healthcare provider offices, or also state agencies when people are applying for and trying to obtain benefits. So we often get asked, and being lawyers, we've tried to look into this, well, what happens when you don't provide language barriers? And we also did a report a number of years ago, it's available on our website, about language barriers and medical malpractice. These cases aren't actually from our report, but I'll show you some of those on the next slide. But you can see that the failure to provide language barriers can actually have financial costs for the healthcare provider. In the report that we did, we worked with researchers at UC Berkeley, University of California at Berkeley, and a malpractice carrier. And we looked at all of the closed claims from that malpractice carrier over a 4.5-year period. And what we found is that that one malpractice carrier had 35 claims involving language barriers and had to pay out over $5 million in damages, settlements, and legal fees. Many of these cases were situations where the patient or a patient's relative or a child was asked to interpret, or the healthcare provider thought that the provider had sufficient Spanish from learning it in high school or college and tried to conduct the medical exam and treatment in a foreign language. And unfortunately, a number of the people involved in these cases actually died or had lifelong medical complications. So what are the requirements to provide language access? Many of you are probably familiar with Title VI of the Civil Rights Act. This law has been around since 1964, and the short version of it is if you receive federal funding, you can't discriminate on the basis of race, color, or national origin. And the Supreme Court and the federal agencies have said language can be a proxy for national origin. So if you take federal funds, you can't discriminate against individuals with limited English proficiency. So what does this mean? It means that LEP individuals must have meaningful access to federally funded programs and activities. And as we said before, who's LEP? Someone who can't speak English very well, excuse me, that really prohibits them from interacting effectively with health and social service agencies. Excuse me, and many of you are probably familiar that back in 2003, the Department of Health and Human Services at the federal level finalized its LEP Guidance, which set out the expectations for those who are receiving federal funds. So what can't federal fund recipients do? And again, this is under Title VI. They can't provide services more limited in scope or lower in quality. They can't delay the services. So if they will serve an English-speaking person, as soon as that person walks the door, they can't send a Spanish-speaking patient away and say, come back next Thursday when our interpreter is available. They can't limit participation in a program based on language, and they cannot require individuals to bring their own interpreters or to pay for interpreters. So Title VI has been around since 1964. Why? What was the thought during the crafting and debate on the Affordable Care Act, why did we think we needed a new civil rights law? Well, in large part, this was due to a number of factors, and NHELP was actually one of the organizations pretty instrumental in crafting Section 1557 and getting it included in the Affordable Care Act. And over the last 6 years since enactment of the Affordable Care Act, we've been working to make sure that we've been able to get regulations out implementing Section 1557. So what's really important to note is that 1557 is not just about language access, and is not just about the race, ethnicity, race, color, and national origin groups that were covered in Title VI, but rather it was looking at all the protected groups and people who might suffer from discrimination in healthcare. It also was important as we were moving into more of a private insurance market as opposed to just Medicaid and Medicare and the Children's Health Insurance Program, that there was a need to ensure that the private market insurers weren't discriminating against individuals on their race or disability or age. Also, as many of you know, enforcing Title VI has been a challenge for a number of years. There was a Supreme Court challenge that limited the ability to enforce Title VI for what's called disparate impact discrimination. I'm happy to answer questions about that if folks have it, but that gets real legal and technical, so I won't go into it right now. But it was very hard to enforce Title VI through the courts. Individuals could file an administrative complaint with the Department of Health and Human Services, and HHS would investigate, but that process could often take a long time and might not provide sort of the relief that individuals could get through the courts. So for a number of reasons, including the limits on Title VI, the need to address a broader array of groups, and the need to address a broader array of organizations beyond federal fund recipients, a number of organizations worked together as the ACA was moving through Congress to look at including a broader non-discrimination provision. So what does Section 1557 do? For the first time in healthcare, discrimination is prohibited on the basis of sex, which also includes gender identity. So there are new protections for transgender individuals. It also prohibits discrimination on sexual stereotyping. And then it reinforces the longstanding protections against discrimination on the basis of race, ethnicity, national origin, age, and disability. Before we had Section 1557, we had 4 different civil rights laws that covered most of these people. So we had Title VI, which prohibited discrimination on the basis of race, ethnicity, and race, color, and national origin. We often think of ethnicity as what color means, but it also covers immigration status and things like that. So we had Title VI. We had Section 504 of the Rehabilitation Act, which prohibited federal fund recipients from discriminating on the basis of disability. We had the Age Discrimination Act. And we had Title IX, which prohibited sex discrimination in education. What Section 1557 does is bring together all of those protected groups into one provision. Because as we all know, you usually just aren't someone of color. When you are a person of color, you also have an age, and you also have a sex, and you may also have a disability. And so the intersectionality made it very difficult sometimes, because if you were discriminated on the basis of, for example, your language and your disability, you might have to go under 2 different laws to get a remedy. What Section 1557 does is brings this all together. And this is really the first time we've had one sort of broad civil rights law, as opposed to chopping it up, and depending on which protected group you are in, you have different remedies and different requirements. So in terms of what both Section 1557 and Title VI do, you can't discriminate on the basis of national origin. And again, as I said before, language can be a proxy for national origin. So that's why both of these laws prohibit discrimination on the basis of language. And HHS, the Department of Health and Human Services at the federal level, issued final regulations implementing Section 1557 earlier this year. So what I'm going to do now is start to go through some of the provisions and the scope of both the law and the final regulations. We do have more information available on our website that explains the final regulations, as well as a summary of the proposed rule, which ended up very similar. And I'm actually looking forward to seeing the questions that you all have after I do the presentation to get the information, to provide more information for you. Okay, so let's go. And I know this is legal, and so I apologize in advance, but that's what we're sort of stuck with when we're talking about this provision. So Section 1557 has a broader scope than Title VI. As we said about Title VI, Title VI covered federal fund recipients. That's the first bullet here. So Section 1557 also covers federal fund recipients. Secondly, it covers any health program or activity administered by an executive agency. Now, these are federal executive agencies. And then any entity created under Title I of the Affordable Care Act. Okay, so we have two additional prongs that go beyond beyond Title VI. So what does this actually mean in practice? Well, under both Title VI and Section 1557, again, federal fund recipients can't discriminate on the basis of language as well as those other categories we talked about. So this includes state, county, and local agencies. So for example, if an individual goes in to apply for Medicaid or goes to a state-based marketplace and is applying, those entities get federal funds, they can't discriminate. It also prohibits hospitals, clinics, and clinicians' offices from discriminating if they take federal funds. Virtually all hospitals in the country are taking federal funds. In individual clinicians' offices, it does depend. If a clinician is only in private practice and takes no Medicare or Medicaid patients, they're not going to be covered by Title VI and Section 1557. If they only take Medicare Part B funding, Part B funds the outpatient services in Medicare, they're not going to be covered by Title VI or 1557. But if they take Medicaid funding, CHIP funding, other federal funding, they will be covered. Title VI and Section 1557 also apply to refugee resettlement agencies, nursing homes, mental health centers, basically anyone receiving federal funds. And it doesn't just have to be Medicaid and Medicare funds. It can be other federal funds. So for example, if an organization has research funding through the National Institutes of Health or the Centers for Disease Control, they are going to be covered as well. As I said before, Section 1557 again goes beyond federal funding. So it also covers federally administered programs. So it covers Medicare. It does seem a little funny to some that you don't think of Medicare as federal funding, but since Medicare is actually administered by the federal government, the way it was interpreted under Title VI was that the government is just funded. It's not considered federal funding. So actually, until President Clinton signed Executive Order 13166, there was no requirement that Medicare not discriminate. The executive order actually applied to the federal agencies themselves, but now Section 1557 actually puts that into federal law as opposed to just an executive order. Section 1557 also applies to the federally facilitated marketplace. That's a federally administered program. In addition, and the third prong of the bullet that we went through of the scope, Section 1557 applies to entities created under the Affordable Care Act, or the ACA, and Title I. Well, what's created under Title I? All of the marketplaces. So federal marketplaces is a federally administered program. State marketplaces were also created under Title I. So if you're in a state where the state is operating its marketplace, it is still subject to 1557. It also means that all of the qualified health plans that participate in the marketplaces are covered by Section 1557. So this takes us sort of out of the public health programs and much more into private insurance, because many of you know that in both the federal marketplace and the state marketplace, these are all private insurers who are selling plans to individuals who are enrolling. And it could be through Blue Cross, it could be through Humana, it could be through Molina. There's lots of insurers participating, and they are now all subject to 1557 as well. So in terms of what happens is the statute itself was included in the Affordable Care Act. So on the date that President Obama signed the Affordable Care Act, which was March 23rd, 2010, this provision actually became effective. It's a really short provision, though. It's only about 2 paragraphs in the law. What then happens with most laws, including 1557, is the federal agencies actually will take that law and determine how they are going to interpret the law and implement the law and put forth regulations. So HHS did this after a long period of time. They first put out proposed regulations, which were subject to notice and comment from anyone who wanted to chime in. They considered all of those comments, and then they finalized their regulations, as again earlier this year back in May. So what I'm going to go through now are some of the major provisions of those regulations with regard to language access. Again, I would just remind you that there are many other provisions in these regulations that outline the requirements regarding prohibitions against sex discrimination, age discrimination, disability discrimination, etc. But let's start walking through what we have in terms of language access. First, the regulations include a definition of who is an individual with limited English proficiency. We saw earlier with the interpretation of Title VI, it's very similar. This is an individual whose primary language is not English and is considered LEP if the individual has a limited ability to read, write, speak, or understand English. About 95% of the time, if someone's unable to speak English, they're also going to be unable to read English. Once in a while, you're going to get some people who might be able to speak or read and not both. But for the most part, if someone isn't able to communicate effectively, it's going to include reading, writing, speaking, and understanding. There are also a number of other definitions in the federal regulation, and they define language assistance services, qualified staff, qualified interpreter, qualified translator, and taglines. So for many of you, particularly those of you who are interpreters or translators or are overseeing and managing interpreters and translators as healthcare providers, this is going to be a new definition for you that you need to take really close attention to. So it says that a qualified interpreter is someone who adheres to generally accepted interpreter ethics principles. Many of you are familiar with the Code of Ethics from the National Council on Interpreting in Healthcare. There are other codes of ethics as well. But an interpreter must be familiar to interpreter ethics, and this includes things such as not being an advocate for the patient and making sure that the interpreter is actually interpreting everything that the patient says and not selecting and choosing and inserting the interpreter's own values. The second piece is that the interpreter has to interpret, or for a qualified translator, translate effectively, accurately, and impartially, and in particular using specialized vocabulary. Again, when we're talking about the medical encounter, we often have very complex terminology. And just because someone might be fluent in a non-English language for general conversational purposes or traveling into a foreign country, they might not be fluent and bilingual when it comes to medical terminology. So this really is almost a two-part test. And a friend of mine who was a doctor a number of years ago said, if you have an LEP patient in healthcare, you're really talking about fluency in 4 languages. It's going to be English, medical English, and then let's say Spanish and medical Spanish. And if you don't have any of those pieces, that person should not be interpreting. The third prong here is that the interpreter must demonstrate proficiency in and have familiarity with speaking or understanding both English and at least one other spoken or written language. What's also implicit in this definition is that just because someone is an interpreter doesn't mean they can translate, and just because someone's a translator doesn't mean that they can interpret. There are very different skills and abilities involved when an interpreter is working with oral communication and a translator is working with written materials. And so it's very important to know that there are different skills and abilities, and you can't assume that one person might actually have both skill sets. So the regulation does not specifically require training or certification for interpreters, whether it be a foreign language interpreter, a sign language interpreter, or a translator. However, as you saw from the definition on the previous page, certification will be one way and probably the easiest way to document that your interpreter actually meets these requirements. And that's in part because the certification examinations do test ethics. They do test that an interpreter knows how to express vocabulary and is able to show their understanding. So it is important that certification isn't required, but it is one way to show and to document that you actually do have interpreters who meet the definition of a qualified interpreter or a qualified translator. Certification can also actually help meet requirements for the Joint Commission for those entities that are accredited by the Joint Commission, because the Joint Commission standards for hospitals also say that staff must be qualified to do the jobs that they're doing. And so again, one way to show that is to show that an interpreter has completed training and certification. It is also important, and I'm sure there's information on CCHI's website about this, that we do have to look at credentialing and certification as part of a continuum. It is a point-in-time testing, and because someone does well on the test, we really are supportive of that and would say that someone is certified, but then we really can't just sort of let them go and expect that they're going to be fine for their entire career. I'm a lawyer, and many of us who are admitted to the bar have requirements for continuing education. The same thing with many other healthcare professionals. There are requirements for continuing education because there are new advances in technology, there's new terminology, there's changes in the standards, etc. So continuing education is a really important piece of the puzzle and does ensure the ongoing and continuing development of one's skills. So back to the 1557 regulations here and what they say about oral language services. It must be provided for all individuals. You can't pick and choose and say we're going to provide interpreters for our Spanish speakers and we're not going to provide them for our Swahili speakers. Especially now with the advent of technology where we actually have a lot of telephonic and video interpreting, you can actually get interpreters in up to 150 or more languages relatively quickly using telephonic means or video interpreting. So how you provide language services may differ based on language or based on the type of entity that you work in, but there is a general requirement that language services should be provided orally for everyone. As many of you know, there are different modes of interpreting, and again, the regulation does not get into specifics. It doesn't require one type of method. It doesn't require consecutive or simultaneous. The basic requirement as an interpreter need to be qualified. So it's important if you are using telephonic or video interpreters that you do want to work with that entity to make sure that their interpreters are qualified. And whether those interpreters are certified or going through some other training and assessment, it's ultimately on the responsibility of the covered entity, which is the hospital or the healthcare provider, to make sure the interpreters meet this definition. So that's an important piece of this puzzle for those of you who are actually working in organizations covered by 1557. In terms of the competency of language services, again, this isn't mentioned in the regulations, but many of you have seen, and I just wanted to give some resources. Going back to the difference between interpreters and translators, we actually commissioned a report from the National Council on Interpreting in Healthcare and the American Translators Association a number of years ago that goes through and explains why there are different skills and abilities for interpreters and translators. And then there's also certification and credentialing available from the American Translators Association, the Registry of Interpreters for the Deaf, and obviously CCHI, which is sponsoring this webinar today. Okay, so let's go back into some more of the provisions of the federal regulation, and then we'll be able to get to your questions. So we often get a question about, well, the LEP Guidance in 2003 said you kind of could use maybe minors or as interpreters or family members. The 1557 regulations are very explicit here. You cannot use minors except in emergencies. Again, going back to the technology, when you can actually get a telephonic interpreter connected usually within less than a minute or so, it's very hard to find a reason that you actually would have to use a minor even in an emergency. Second, it also explains that an accompanying adult should not be used except in an emergency or upon a patient request. I often get questions, well, okay, if the patient brings his or her family member, can we use that person as an interpreter? And again, I think it goes back, you've got to look back at that definition of a qualified interpreter. If you know, or even have reason to know, if you suspect that that family member or friend coming and trying to interpret is not qualified, then I would make sure that you actually are finding your own interpreter in addition. So what a lot of entities have sometimes done is if a patient does want to use their family member or friend, is first they make sure that the patient understands that there's no charge for using an interpreter and that the patient will be served as quickly as an interpreter can be obtained. Second, if the patient still wants to use a family member or friend, a covered entity still has the ability to have their own interpreter sit in and make sure that the communication is effective and make sure that that interpreter is competent and qualified. And that can actually help protect the covered entity from any problems that may arise if during the course of the conversation or the office visit, it actually becomes pretty evident that the accompanying adult doesn't know the medical terminology or doesn't understand the ethics of interpreting, in which case the qualified interpreter from the entity can take over. Okay, so in terms of other requirements in the regulations, there's also a new requirement for notices. So any employer that has at least 15 employees must provide notice about its non-discrimination policies. And it has to designate at least one employee to carry out the responsibilities of complying with Section 1557. And this includes having grievance procedures and due process standards. These notices can be posted in English. They can also be translated into other languages. But at a minimum, an entity must post the English notice with taglines in the top 15 languages in the state of the covered entity. A tagline, if you're not familiar, is a very short statement, and there's actually a model tagline in the final regulations that says, this notice is important, and if you can't understand it, here's a phone number to call to get oral language services. So it's not a requirement that this notice actually be translated, but the taglines help LEP individuals understand that there is a way that they can request oral assistance if they can't read the English notice. The regulations do not include any specific thresholds about translating documents. However, I do want to emphasize that the 2003 LEP guidance from HHS is still in effect. So these regulations on 1557 complement and supplement what has already been in place since 2003 through guidance and since 1964 with Title VI. So the 2003 guidance represented translating vital documents. And many of you might be familiar with the safe harbor provision that said if you translate documents, if you have 5% of your population or 1,000 individuals who speak a particular non-English language. So if you're in a community that has a large Arabic-speaking population and more than 1,000 people in your patient population, if you're a hospital, speak Arabic, and you translate that document, you're definitely in compliance with Title VI. Section 1557 takes a different framing, and instead of using the term vital documents, it talks about significant documents. And it requires these taglines to be in all significant documents. So there's the notice that I talked about, but also any significant documents, such as maybe a patient handbook, or I would say a bill, a statement of benefits, anything that affects a patient's rights, should also include these taglines to help LEP individuals understand that the notice or the document is important and that they probably want to get some information to assist in understanding it. So there are a number of resources that can help covered entities comply with these regulations. The Migration Policy Institute has a lot of data available as well. And then, of course, we have CCHI's webpage that has resources for healthcare providers. So at this point, I'm going to wrap up the formal part of the presentation, and luckily I left a lot of time to answer your questions, so I'm really looking forward to that part of the conversation. And I will turn it back to Natalia to explain how people can write in their questions or how we're going to proceed with the question and answer portion.
Thank you very much, Mara. Yes, please continue writing the questions. We have received already several, and I will go through them. I will start with a question which I think like most of people put on into the question box today, and that is what are the implications of the election results that we just learned yesterday to Section 1557 and to the Affordable Care Act. One of the specific questions is if the Affordable Care Act is repealed, will Section 1557 be still in effect? What can you comment? Obviously, we know you cannot give us the full answer and give the step-by-step instructions, but what can you tell us about this?
Sure. And it is still, obviously, we're only about 36 hours out from getting the results of the election, and we don't have a lot of details yet. While the call has certainly been to repeal Obamacare, Obamacare is a very, very large and very significant law that has lots of pieces of the puzzle. And what is unclear for these calls to repeal Obamacare, if it is really focusing on the private insurance and the marketplace side of things, or if it's repealing Obamacare as a whole. So it's very hard to know what will happen to Section 1557 at this moment. You know, we're looking at it, and we'll be putting out some information as soon as we can, but I actually spent my morning trying to sort of write what implications this might have, because it's not just, we have 12 million people who are now enrolled through the health insurance marketplaces, but we have another 13 million individuals who are now enrolled in Medicaid in the states, mostly through Obamacare. We made significant changes to the Medicare program through Obamacare, and there's other provisions such as the ability of individuals to stay on their parents' health insurance until they're 26, to get free preventive care, to eliminate lifetime limits and yearly limits on, you know, costs and things like that. So it's still very new to try to figure out what's going to happen. And some of it is, we will just have to wait and see, are they really talking about all, you know, 1,000 plus pages of Obamacare, or is it, you know, bits and pieces here and there? But what I do want to emphasize is many of the requirements that came about in Section 1557 pre-existed 1557. As we mentioned, and this is why I talked about Title VI, it's been around since 1964. And so anyone who receives federal funds can't discriminate. And even though 1557 sort of now adhered to the federal marketplace and the state marketplaces also receive federal funding. And all of the qualified health plans that participate in the marketplace also receive federal funding, because they're getting payments from the federal government to help subsidize premiums and cost sharing for lower income individuals who are participating in the marketplaces. So even though we saw 1557 as an important way, as I said before, to sort of bring together 4 different civil rights laws, most of the requirements regarding language access will still be in place regardless of 1557. So 1557 may have brought some highlighted focus on it, some new expectations in the regulations, and some sort of overlays between, as I said, the intersectionality of discrimination on the basis of disability, age, sex, as well as race, color, and national origin. But the reality is that many of those requirements were in place since 1964, were in place since the executive order was signed in 2000, were in place with the HHS LEP Guidance. There may have been some pieces clarified or explained better in the final 1557 regulations, but truly, if Obamacare is repealed in its entirety, that does not allow recipients of federal funds to start discriminating on the basis of language in healthcare.
Thank you. Thank you. And a connected question to that, so if the Affordable Care Act is repealed in its entirety, how long do you think it'll take? How long do you think it'll take to sunset this, so to say, this program? Will it happen within a week or month or years?
Again, it's hard to know, and again, it's tied up in the fact that even though we now will have, come January 20th, a Republican president, a Republican House of Representatives, and a Republican Senate, in order to repeal Obamacare, they still all have to agree, and they have to go through the legislative process. So is it likely going to be repealed on January 21st? I think not. Well, that might be actually a Saturday, or whatever the first day is after, work day is after the 20th. I think the 20th is actually on a Friday. Probably not. There's also been some talk, even in the last 24 hours, that even if it is repealed, that there will need to be a winding down period. You can't just shut off health insurance for 25 million individuals. We also have already seen some statements from governors who actually support the Medicaid expansion, which was part of Obamacare, and support having the marketplaces. So it will be interesting to see how this plays out. I wish I had a crystal ball and could predict the future better. But again, I think it is going to take some time, both to just, 1, get through the legislative process, and 2, provide some transition. So, you know, for folks enrolling right now in the marketplaces, you know, I certainly would hope that they would at least keep their insurance through 2017, which is what they're expecting when they sign up. And I certainly hope that it'll continue beyond that, but we'll have to sort of wait and see. But again, even if Congress and the President repeal Section 1557, the same requirements are going to exist under Title VI, and no one has talked at all about repealing Title VI. That's been around for over 50 years.
Thank you. Well, now that we have the most urgent question out of the way, I'll go down the list of questions that I received. Have you seen or have you noticed any increase in litigation since July, which invokes Section 1557 and Title VI?
I haven't seen litigation per se on the requirements regarding language access. There have been a couple of cases filed on behalf of transgender individuals who are covered by this regulation, since we now prohibit discrimination on the basis of sex and gender identity in healthcare. But again, I think for most people, the way that this law will be enforced is through administrative complaints, by filing a complaint with the Office of Health and Human Services. If people are interested in the litigation aspects or considering litigation under 1557 language access, I would ask them to reach out and talk to us first. You know, part of this is it's going to be interpreted by the courts, just as it has now been interpreted by HHS in their final regulations. And so we are sort of looking to see where things will go as cases start to wind their way through. But for most individuals, the time, effort, and expense of going through court might not be worth all of the steps that it would take, and instead filing an administrative complaint and working with HHS to rectify the issue and prevent discrimination going forward might be the best solution in individual cases at this point.
Thank you. Kind of related question. How much time does it normally take to get a decision if one files a discrimination complaint with the Office for Civil Rights?
That one really depends, and that one actually could change after January. You know, it also depends on, is this really a case that's of sort of first impression or new, or is it something that they've addressed before? So, for example, NHELP actually filed a complaint under 1557 against 4 insurers in Florida, alleging that the way that they designed their prescription drug benefit was discriminating against people with disabilities, in particular people with HIV or AIDS, because these insurers put all of their HIV drugs in the highest tier of the pharmacy, meaning they were very expensive. That was a case of first impression, and it's still being worked on, although there have been regulations that have subsequently come out saying you can't discriminate in benefit design. So while we don't have an official decision to our complaint, actually the Florida Department of Insurance intervened and addressed it with these insurers, and HHS addressed it in regulations governing all insurers in the marketplaces. But I think if you're talking about a pretty typical complaint, it might take less time. And again, since we've been able to file complaints under Title VI, you know, for decades, there is a long history of what needs to be done. So it does depend somewhat on your region of the country, since many of these cases are investigated by HHS's regional offices. It also depends sometimes if there's, you know, a pattern going on as opposed to just a single case. But it is really hard and difficult to sort of give a time frame, unfortunately.
Thank you. Some different kinds of question now. Is there in Section 1557 some language regarding modality choice for interpreters? Does the patient have to be offered the choice in whether it's a face-to-face interpreter or telephonic or VRI, or is it the provider's decision?
The regulations do not address that, and I would say, you know, this is a question we get a lot about. Not as much for the foreign language side, but sometimes for sign language. You know, a video interpreter is offered, and the deaf or hard of hearing patient turns it down, saying they want someone in person. I'd like to take this a little bit out of the 1557 context or the Title VI context and put it back in the patient-centered care context. And so is there a valid reason that a patient may have for preferring or wanting in-person over telephonic or video? And there certainly are times when having a telephonic interpreter may not be as effective as in person. So for example, if you're demonstrating how to use a particular device. Let's even just take a nebulizer for a child who has asthma. If you have an in-person interpreter, that person's going to be able to point to the same switch the doctor just showed about where to turn it on or where to insert the medicine or where to position the mask. A telephonic interpreter might have that difficulty because they can't see what's happening in the room. So there might be a valid reason that a patient has for requesting one modality over another, and I think that that's important to explore. But there are not any requirements for which modality, and in fact, under Title VI, what we've said for years is, part of it also is just the balance of languages. You're not expected to have full-time interpreters for all of the languages that you may ever encounter. Is it going to be more efficient and cost-effective to have in-person interpreters in some of your more frequently used languages? Probably yes. Telephonic and video can get expensive quickly, and if you're using them a lot, having someone on staff more readily available in person actually may cut down on your costs. But this really is sort of a case-by-case basis, and it depends a lot on the covered entity, what types of services are being provided, what the patient's needs are, et cetera. I mean, wheeling in a video cart to the emergency room often is not going to be most effective for positioning as well if someone's in a trauma or crisis. So, having in person where someone can actually stand behind a patient might be better than wheeling in a big video card or even a telephone with a speakerphone to try to do communication.
Thank you. I have a couple of questions about what is considered a critical document. One question asks, would that include a hospital general admission consent, or is it a document on which the patient signs off? Do you have any clarification about that?
Sure. I do want to go back and say so that the terminology is actually a significant document must include taglines. A vital document should be translated, and again, there are those safe harbor distinctions. So those are the two different terms of art to some degree that we have in the regulation of the LEP guidance. What I would say, and again, while I am a lawyer, I cannot give anyone legal advice on this, and I'm a policy attorney, but I'm doing this as education and not legal advice. But in general, if you are talking about a document where you are getting the patient or the patient's parent or guardian's consent to do a procedure or a course of treatment, that's a relatively important document. And so that's probably going to rise to the level of needing to either be translated or to have a process where the provider is going through and explaining the document to the patient and making sure that the patient really does understand it. It is not the role of the interpreter to explain the document. So if you have an informed consent document, the provider can't hand it to the interpreter, say, read this to the patient and walk out of the room. The provider still has the responsibility to obtain the patient's consent and to ensure the patient understands what is being consented to. So again, it might depend on the nature of what we're talking about, a flu shot versus surgery for an appendectomy. You really want to make sure that someone understands what the potential complications are if they're having an appendectomy, of anesthesia, a follow-up of everything else. Even with the flu shot, though, some people have adverse reactions. So it's hard to give hard and fast answers on that. And certainly if you're a provider, literacy levels are also important. Many informed consent documents are written at such a high literacy level that even if they're translated, your LEP patients aren't going to be able to understand them. So there's sort of many different components to this, and it's important to think about how you can address this and make sure that you are getting informed consent and that you're documenting the informed consent. So if you are using a document in English and you're having an interpreter, it's going to be important to make sure that there's some documentation somewhere in that patient's record that the provider used an interpreter, the provider explained everything to the patient, asked if the patient had any questions, and how that provider obtained actual informed consent.
Thank you very much. There were a couple of questions about taglines. So first of all, they wanted confirmation that the tagline goes on the English document, not on the translation. And then secondly, how do you determine the top languages? Do you follow the census, the HS guidance, or can you as an entity determine yourself what are your top languages?
Sure. So where taglines go is actually an interesting question, and I would say you want to make sure that the taglines are in a location that they are going to be found by your LEP patients. So if you are sending out a 15-page document and they're on page 15, I'm not sure many LEP folks would flip through 14 English pages to then find the tagline on page 15. So I really think we have to be talking about effective notice and not just sort of, complying with the letter of the law. So again, it's going to depend. What it does say in the regulations is on websites, it should be on the home page. Or if it's not on the home page, there should be an easy way from the home page to see how to get to a page with taglines. So maybe it doesn't have the entire tagline in 15 languages, but it would say Espanol, and you'd click on Espanol, and you'd get to the tagline page, and it would say that in 15 languages. There are some creative ways to do it in Washington, D.C. They had a requirement for 5 taglines pursuant to a citywide law. They were able to do it in a header. So I think it is sort of thinking about what type of document, how long the document is, etc. There is an understanding in the 1557 regulations that if this is a small document like a postcard or a trifold brochure, that you only have to include 2 taglines and not 15. In terms of the data and where to get it, HHS has published the top 15 languages in every state. So to some degree, that's the easiest way to get it. However, if you have differences based on your patient or client population, you certainly could use the top 15 that you think are relevant. I would just make sure that you have documented somewhere how you came up with those 15. I think what's also important to note is it's not just who you are serving, but who is eligible to be served. So if you are only seeing individuals in 3 languages because you have interpreters in those languages and you haven't provided interpreters in other languages yet, but you are living in an area where you know there is a high percentage because of census data or maybe state education data from the schools or something of those other languages, then just relying, for example, on your admissions data might not be sufficient in determining your taglines. There is also an understanding that if a covered entity operates in more than one state, that they can aggregate the taglines between those states. So they can pick the top 15 amongst all of the states that they work in. So that may end up with some different results. So if you work in Maryland, New Jersey, and Iowa, you don't have to have 15 plus taglines if you end up with more languages. Instead, you would just aggregate that data and then pick the top 15 languages amongst those 3 states.
Thank you. A very interesting specific question here. Many clients, medical facilities, are interpreting Section 1557 in such a way that they think that they need to provide a multi-language helpline to the LEP population. In other words, they want us, it seems like a language provider, to create a multilingual helpline where we interact directly with the LEP patients. And therefore, we are not interpreting, but rather becoming an answering service. Are they misinterpreting Section 1557?
Well, again, this is probably going to depend on the circumstances, and it's a little bit hard to answer that. There's nothing wrong with a helpline or an advice line where you can provide services directly in a non-English language if those bilingual or multilingual staff are qualified. So, for example, there are some health plans that have a nurse assistant line and may have bilingual English and Spanish nurse assistants who can then answer the phones and provide assistance directly in English or Spanish or other languages. And as long as the folks staffing that line are competent both in their ability to provide services as a bilingual staff or an in-language staff person, as well as the competency to answer the questions, that would be fine. I think where it would get into trouble is if this is something where the level of knowledge is such that it's important to have a provider be able to answer questions or explain. So it's a little bit challenging, but the regulation does define, just like it defined what a qualified interpreter and a qualified translator is, there are definitions of qualified bilingual and multilingual staff. So if you do have someone who actually is sufficiently bilingual and knows the medical terminology, by all means, that person should be able to provide services in a non-English language directly and not have to use an interpreter. Where it gets tricky is when you have someone who may have a limited language capacity in a non-English language and they think that they're sufficient to interpret and they're going to miss critical information when they're doing an examination or taking a health history. So I'd be happy to maybe have that person email me directly with more information. It's a little bit hard to answer in sort of this abstract way.
Thank you. Another question is about the fact when the patient brings their own interpreter and they decline the interpreter provided by the facility. Should there be some documentation that the qualified interpreter was offered, and how do you deal with that if it is specifically a pediatric situation and the parent refuses the services of the interpreter for their child?
Sure. So first of all, I did back up to the very first slide, so you hopefully can now all see my email, and feel free to email me or call me at NHELP's DC office if you have questions. I'm out of the office a lot of the next 2 weeks, but I'm happy to get back to people probably more like early or mid-December. So if a patient or the parent or guardian of a patient declines the use of interpreter, absolutely, that should be marked in the medical record. However, as I was discussing before, if the provider or entity knows or suspects that the person acting as an interpreter is not going to meet that definition of qualified, then just having a note in the record that an interpreter was declined is likely not going to be sufficient, particularly if there's harm or malpractice or negligence that comes up. So that in those situations, we do recommend that again, you try to educate the patient or the parent in the pediatric setting about why having an interpreter is useful. You know, part of it is sometimes our LEP patients don't understand the U.S. healthcare system, or they may think that they're going to be charged for an interpreter or have to wait, you know, hours when an English-speaking patient would be served quickly. Other times, it's just that if you can explain that, you know, particularly in a pediatric setting, the parent's role should be as a support or an advocate for the patient and not as an interpreter. And if the parent is trying to do both roles, the parent may not be able to be as effective as the support or the advocate because they're trying to interpret. It puts them in a difficult situation. So I would certainly say to definitely document it, but also to really consider having your own interpreter present so that if it does become apparent that the person serving as an interpreter is not qualified, either they're not interpreting everything both ways from the provider and from the child or the patient, if they don't have knowledge of the medical terminology, you know, it can be pretty obvious. The patient says, you know, a minute of speech, and then the interpreter says, you know, 10 seconds. That should put any provider on notice that that interpreter is not fully interpreting everything the patient says. And a parent obviously also may have some conflict with their child, depending on the type of medical visit it is. And the parent may have opinions about what the child should or should not do. And so there's also potential just conflict of interest in those situations where making sure that the child, particularly if it's an older child like a teen, does have his or her own ability to communicate with the provider would be important.
Thank you. Thank you very much. We have many more questions, but we already have just 1 minute left of this hour that we dedicated to the webinar. I will forward some of the questions to Mara, but also please contact her directly at Youdelman@healthlaw.org, and as she graciously agreed that she would be happy to answer your questions. On our website, on CCHI's website, within the next couple of weeks, we will have the recording of this webinar available, along with the main links to the resources mentioned in this presentation, and we'll have the links to the list of top 15 languages, the resource provided by HHS about the top 15 languages available. Now, the logistics as far as the attending this webinar, if you need a certificate of attendance, it will be emailed to you within the next week by November 18th. But if you will not receive a certificate of attendance for any reason, please email us and provide the following attendance code, which is 89K5W7. I'll repeat, 89K5W7. I want once again to thank Mara for coming talk to us today, especially in such an uncertain situation that we're all facing as a country. It was a very informative and very useful presentation. Thank you very much.
Thank you.
Have a wonderful rest of the week, everyone. And look forward to you attending other webinars from us. Again, I will follow up with the email with the resources page and the certificate for attending this webinar. Bye-bye.